Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article, number 17. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. Article 17, Pain is Not the Only Problem. Subthreshold, Microtrauma, Part 1. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative, non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Subthreshold microtrauma, as described by Dean, 2016, describes subclinical soft tissue and hard tissue damage, implying that the patient is asymptomatic and not seeking care, and is likely due to an abnormal movement pattern and associated with a symptomatic area of tissue, but not always at the symptomatic area. I'm going to read this again with a little more detail. Subthreshold microtrauma describes subclinical soft tissue damage. Soft tissue damage being voltage gate tissues, muscle, fat, fascia, lymph, arteries, veins, and nerves, and hard tissue damages, collagen-based tissues, bone, ligament, tendons, cartilage. So together, these subclinical soft tissue and hard tissue injuries are occurring, but the patient is asymptomatic and not seeking care. However, the tissue damages are still there and is likely due to an abnormal movement pattern or a faulty movement pattern and is associated with the symptomatic area of tissue, but not always at the symptomatic area. Remember, we're talking about subclinical soft and hard tissue damage injuries where the patient has not sought care. The subthreshold microtrauma theory states that a system of movement patterns employs muscles and joints that fire together on the same nerve network, also known as Hilton's law, combined with other movement patterns employing muscles and joints that fire together by other nerve networks that are not synchronized sufficiently to produce a functional movement. Therefore, these other movement patterns contribute to tissue damage within that system. Movement pattern synchronization employs groups of actions, for example, walking. During a walking gait cycle, the ankle extends while the knee flexes, while the hip flexes, while the hip rotates, while the sacrum counternutates, forming a synchronized group action. Subthreshold microtrauma identifies any subset of the group as faulty, not the entire group. The faulty subset may have been self-learned or due to poor or wrong instruction, de facto due to personal bias, or to creep by fatigue, and is never identified by one muscle and certainly not a muscle described as tight, short, turned off, weak, for example. Subthreshold implies subclinical tissue damage that does not have the attention of the patient, the athlete, and they have not sought care because there are no presenting symptoms that are annoying them enough to cause intervention. The patient athlete might notice minor changes in performance and brush them aside as episodic. Microtrauma implies non-traumatic, incidental tissue damage that does not evolve into the acute phase of healing. There is no noticeable soreness, redness, inflammation, or tenderness. However, there is enough tissue damage to cause motor efficiency to change, such as time under tension, known as strength, loadability, known as plyometrics, total recruitment, known as load, active range of motion, known as mobility, capsular stress thresholds, known as stability, innervation, known as precision, metabolic delivery and waste removal, known as biochemical, and modality, known as novelty. Initially, the patient's faulty movement patterns contribute to repeated temporal subclinical spikes of acute tissue damage that tend to resolve with the usual phases of healing. However, performance seems normal. Eventually, repeated faulty motor patterns overburden the usual phases of healing, and the tissue repair is incomplete, insufficient, or defective. Instead of restoring the motor and connective tissue to full function, they are replaced with scar tissue or incomplete tissues and altered motor mappings. Inflammation accumulates since clearance rates are encumbered by spikes of re-injury. Repeated faulty motor patterns over time drive complete recovery to fail. Multiple phases of healing overlap and tissue repair becomes impossible as the faulty motor pattern becomes an assault. Optimally, asymptomatic faulty motor patterns are identified and corrected into a productive and useful skill or functional motor pattern. With enough repeated and unresolved acute spikes and tissue injury, the patient athlete will begin to experience symptoms and experience repeated failures to control movement patterns. In many cases, the early warning signs are disregarded, and the patient athlete persists with the assaulting activity. Then one day, the patient will feel symptoms with movement and experience the usual calor, dolor, rubor, and functio laissez, and the patient seeks care due to symptoms. But I have not said all. In the background, the patient's faulty motor pattern has taken a detour in an attempt to remain functional at all costs. By diverting the demands of the faulty motor pattern into an alternate faulty motor pattern, the second generation faulty motor pattern employs different, unaffected muscles and may even change whole body gravity dynamics, shifting the weight, approaching the skill with more force or aggression, and the patient seeks out care only after the second generation faulty motor pattern has failed, since now performance of any kind is impossible. Patients with low back pain in your office actually have 5 problems. Can you imagine what they might be? Number 1, a complaint of back pain. Number 2, a faulty movement pattern. Number 3, a secondary faulty movement pattern. 4, repeated failed attempts at healing. And 5, emotionality related to unresolved low back pain. A focus of only pain resolution is a diluted attempt to case manage low back pain because pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-culture willingness to strengthen medicine. Thank you.